Good afternoon and welcome to the Assembly of Osteopathic Graduate Medical Educators AOGME webinar series. We are pleased to have you join us for this GME Development Series webinar on strategies to launch rural residency programs in critical access hospitals. My name is Austin Wetmore. I'm the Program Manager for GME Initiatives at ACOM, and I will help facilitate this webinar. Before we get started, I'd like to review a few housekeeping notes. This webinar is being recorded. The recording will be posted on the AOGME webpage shortly. All webinar participants are in listen-only mode. If you experience technical issues during the webinar, please use the chat feature and we will assist you. If you have questions for the presenters during the webinar, please feel free to submit them through the Q&A feature at any time. If time permits at the end of the webinar, they will respond to your questions. I will now briefly introduce our presenters. Dr. John Bull is the Program Director for the UPMC Rural Family Medicine Residency Program. Since joining the program in 2012 as faculty, Dr. Bull has focused on teaching and mentoring students and residents for practice in underserved communities, including the rural and Amish communities. Lori Rodefeld is the Director of Rural GME Development at the Wisconsin Collaborative for Rural GME, where she engages with stakeholders statewide and nationally to expand rural residency training. She also serves as the Director of GME Development with the HRSA-funded Rural Residency Planning and Development and Teaching Health Center Planning and Development Technical Assistance Centers. Thank you again to Dr. Bull and Lori for joining us today and for preparing this presentation. With that, I will turn it over to them.
Great. Well, thank you, Austin, and thank you, AOGME, for allowing us to present today on growing rural residency programs in critical access hospitals. I want to take a moment and just express my appreciation for the role that critical access hospitals play in rural GME development. I know that our experience here in Wisconsin, it has been a key piece of our GME development strategy, and then working with the RRPD Technical Assistance Center and the Teaching Health Center Planning and Development Technical Assistance Center. We've seen many critical access hospitals step up and become engaged in GME development efforts. And I'm really excited to be joined by Dr. Bull, who is one of our RRPD grantees and has just a really great story of growing a new GME program that will be recruiting its first class this year and hopefully successfully matching next week. And you'll be able to learn a lot from him. As we get started, we do need to share some disclosures. First, Dr. Bull and myself, we do not have any relevant financial disclosures to share with you other than we are both passionate about rural graduate medical education and growing programs in critical access hospitals. I do also need to mention that RRPD and THCPD are both supported by HRSA, and they provide great funding to grow residency programs in rural and underserved communities. However, the content expressed today does not necessarily represent the official views nor an endorsement of HRSA, HHS, or the federal government. Our objectives today are really to share some stories with you about rural health disparities and the impact that critical access hospital training can hopefully impact future rural practice and creation of future rural doctors. We want to talk about different models and considerations as you look at establishing GME and critical access hospitals. We also want to talk about some resources that are available to help support startup and support GME development efforts in rural hospitals and in critical access hospitals. And then lastly, we will share some examples of residency training models in critical access hospitals. So we want to start and talk about why do we train residents in rural settings? And I think that really, the key reason is that because we have expertise, we have deep expertise within these rural communities. We have communities with experienced doctors who have a broad scope of practice, things that you may not always find in a larger urban community where there's multiple specialists to refer patients to. Instead, doctors who are used to kind of doing it all, being a rural generalist. And John will talk a little bit about that in a little bit. We also know that setting and training matters. Imprinting happens when we bring residents into rural communities. You'll see on our next slide that there's evidence to show that they will practice rural, and creating rural training programs is a key approach in growing our rural physician workforce. We also know that there is a phenomenon that residents will practice within 100 miles of where they train. The vast majority will, and if we can sprinkle rural residency programs into communities that need doctors, we will make an impact. We also know that our rural physician workforce is an increasing priority for rural hospital leaders. Just last week at our rural Wisconsin Health Cooperative meeting, we had a strategic planning session with many hospital presidents in attendance. And for the past few years, they've all stated workforce is their number one priority, and rural physician workforce is their number one priority as well. So we have a captive audience. We have hospital leaders looking to become engaged in creating more rural doctors. So now is the time to build those partnerships and build those relationships. And then, unfortunately, only 2% of residency training is occurring in rural areas. So there's opportunity to grow. We've seen urban programs grow, we've seen rural programs grow, but in total, that percentage has remained about the same. And then lastly, we know, like I've said already, rural residency training is a proven strategy to grow rural physicians. There's a study done by multiple folks who are experienced in rural workforce research showing that residency training impacts future rural practice. And I love this graph, and this really highlights the importance of rural residency training. You'll see students who are from an urban background are twice as likely to practice rural if they attend a rural residency program. You'll also see that if a rural background student attends a rural residency program, they are twice as likely, 81% likely to practice rural in the future. Rural residency training, we've known for a long time, makes a significant impact in our rural physician workforce, and this slide absolutely proves that this is a great strategy to grow our physician workforce. I'm going to hand it over to Dr. Bull, and he's going to talk a little bit more about training with and for rural communities.
Yeah, hello everybody. It's great to meet you. I worked for 10 years in Tennessee in a critical access hospital and have been part of the residency here since 2012 in Williamsport, Pennsylvania. And over the last 4 years, we've been developing a rural residency, and we're just recruiting our first class. Next week, we find out who we matched. So we're real excited about that. For those of you who have started a residency, you know, it's like birthing a child in a lot of ways. There's a lot involved with it. And it's so exciting when it comes to fruition. Um, I put a lot of thought into, you know, how to set up curriculum in a rural residency, you know, based upon my time in practice in Tennessee, but then also in teaching. And there's a few articles that I thought might be really helpful to share with you. And that's kind of what I'm going to share over the next few slides here. And the reason is because they have really key concepts as you think about, you know, developing a rural residency in your community. This is actually an article published by Dr. David Smits, who's done a lot with the Rural Training Track Collaborative and in the rural education arena. And basically, he talks about a couple of key concepts in rural medical care, similar to what Lori talked about as well. But the importance of this whole concept of situation adaptation, where you know, the importance of place when it comes to training. And so historically in the US, there was this thought that you needed to train near a major university. And that may be still true for certain specialties, you know, like especially where you have to do a very specific procedure that you can only get at a major medical center. But for many other specialties like psychiatry, you know, even some general surgery, family medicine, pediatrics, you can really gain a lot by training in the location of where you're going to practice in the future. The other concept that he brings out here is just about the whole concept of first contact and learning as a rural physician. How do you handle that first hour of trauma care or maternity care? Rural comprehensiveness, and it's something that I ran into quite often in Tennessee, where I did not have access to GI or infectious disease or sometimes dermatology. So the expectation was that when I saw a patient, I had to actually provide them care that would be not only what a normal family physician would do across the country, but also what perhaps some of those specialists would do as well. And then the final thing that really is a key as you're considering about developing a rural residency is this whole concept. It's actually from the ACGME, but it's the idea of a master adapter learner. And there are so many things that are involved for like my specialty in family medicine that you can't learn it all in 3 years. But what you're trying to do is set the framework so that once the resident is out in practice in your rural community, that they can continue to learn and they can continue to be able to meet the needs of their community. Next slide. A second article that kind of highlights some of the things that Lori talked about before, but I would encourage you to consider reading. It's called Cultivating Country Doctors. And the magic window really for, you know, if you're looking for statistical significance is 12 weeks to get a medical student or a resident out to a rural area in order to get them to practice in that rural area in the future. But I personally feel any exposure is helpful. So for example, our program here in Williamsport last week, we had 5 medical students first year from University of Pittsburgh who came and spent the week, and we had them rotate every half day through a number of different areas of the hospital. They went out with EMS. I took them out on Amish home visits. And they got to work with trauma surgery with OB-GYN who did some robotic surgery. They were able to work with telemedicine and they had a great experience. And I know that 1 week may be a small amount of time, but you know, anything that you can actually involve them with, even if you aren't able to develop a residency, can be really, really super helpful. Next slide. I mentioned a little bit about first contact, but there's these 4 pillars of primary care, and it's first contact, comprehensiveness, coordination, and continuity. And later on, I'll show you our curriculum in our program. But the idea that I think is really important is to think about what is different about these 4 pillars when you're talking about an urban versus a rural area. Now, some people might say that these 4 pillars are similar in all underserved communities, and I think there's some truth to that. So whether it's rural or global or you know a Native American reservation or an urban area, like there are some similarities between what these look like. But you know, in a rural community, and actually, if you could go to the next slide, in a rural community, your comprehensiveness might look much different, like I mentioned before. And I just want to give another example. So where I worked in Tennessee, I had a good friend who was a general surgeon who helped us all the time. And he became our GI doctor in town. So his comprehensiveness was much different. He also, you know, ended up providing continuity because he worked there for a long time. As you guys probably experience in your town, if you're the only surgeon, you have quite a bit of continuity with the families. He had a much broader scope of practice, meaning that he also did gynecological surgeries, pediatric surgeries, and he also provided first contact sometimes, which is much different than what you might see other places. So whether it's family medicine or something like general surgery or psychiatry, it's trying to train those people in the place where they're going to practice is really super important. Next slide. And finally, I just wanted to highlight this. You know, so this is a really well done study by Dr. Randy Longenecker. It's often highlighted, but he published this in 2017 or 18. And essentially what he did was he surveyed physicians in metropolitan areas and rural communities. And he wanted to find out, okay, so what are competencies that you need in those locations? And what he found is, and I highlighted it here, is that scarcity was the most extremely unique thing about a rural community. And you know, for all of us that work in a rural area, would say, hey, that's not surprising at all. Scarcity, though, is a economic, you know, term, and it really describes that you basically have less than what you think you need. And I found that true all the time when I was working in Tennessee. And when it comes to preparing residents to work in rural areas, it's very important that we acknowledge this. And this is one of the most important things that they can learn by working in those rural areas. And there are studies out there that show that if a resident works in an area of scarcity with low income and low resources, that they will go out and practice and carry that with them. And actually, it'll follow, even if they go to a high resource setting, it'll follow them for 8 years after they get there. So your training of them in an area of scarcity actually helps them to be successful there as well. Randy also uses this term scaling to small places, right sizing to community capacity. And I put this picture here, which is, we were driving in the Wind River Range in Wyoming, a couple of my friends and I, and going backpacking, and we came across these two calves in the middle of nowhere. And if you looked around 360, there's nothing else there. And we were just kind of shocked by the calves that were there. But really, you know, kind of felt like that sometimes in Tennessee as well. But we're not trying to overwhelm our rural communities with our education. We're actually trying to really tailor things to make it so that the residents and the rural community can be as successful as possible, which is kind of where your curriculum comes in. Next slide.
Great. Well, thank you, Dr. Bull. I love, that last slide and the reference to scarcity. And I think it really ties in nicely as you look at, what are your training options when you're looking at a critical access hospital? And I think I've heard time and time again, since I've been in the GME development space, if you've seen one rural program, you've seen one rural program. And it kind of is true whether it's rotations, whether it's a rural track program, or if it's just a traditional rurally located program. And there are many options. And I think it's a matter of finding, what's possible at that critical access hospital site and how can you work with that team to really provide good quality experiences. And even rotations are a really great way to get started. So I do want to talk about that a little bit. In Wisconsin, we've really worked to develop a lot of rotations for urban programs that are interested in engaging with rural communities, and critical access hospitals are a really great option. You'll see on the funding side coming up why there's a lot of interest in growing rotations within our critical access hospitals, but also we just have a lot of critical access hospitals that are interested in becoming engaged with GME. So I'm going to give you a couple of examples. We actually have over 15 rotation sites, plus many rotations at each of the sites. But one of those examples is Baldwin, Wisconsin, which is in the far western part of the state. It's about an hour from the Minneapolis-St. Paul area, but in a rural community with a beautiful hospital where they provide training to the OB-GYN rural track from the University of Wisconsin, as well as the rural track for surgery from the University of Wisconsin. And they offer several rotations to those residents and provide just a really great high quality experience. I was able to visit there when a OB-GYN resident was rotating, and she reflected on her experience of being able to kind of do everything because in a traditional OB-GYN program, she's on, her delivery service or she's in surgery. She's not doing all of those activities that you do as a rural doctor all at once, where you're rounding on your patients, you're seeing patients in clinic, you're going to the ED for a consult, you may be delivering a baby, going to section. There's just a lot of variety that you have in a rural place. And if your goal is to become a future rural doctor, to be able to get that experience and develop that confidence and really develop that mentorship, it's really key for their long-term success and eventual placement in rural practice, because it hopefully validates the work that they're hoping to do, but then they build these strong connections and see that it's possible. Similarly, the rural surgery program, that's a newer rotation, but they get to work with both an experienced surgeon and a newer surgeon. So they get kind of both ends of the spectrum in working at that hospital. And what's really exciting is this past year, they've been able to coordinate some of those rotations when the OB-GYN resident is there at the same time as the surgery resident. resident, and the surgery resident is actually being taught by the OB-GYN resident as well as the OB attending on how to do C-sections. And our rural general surgeons need to learn how to do C-sections. So that's been a really great way for Baldwin to kind of experience GME and get their feet wet and see, is this something we'd like to do more of? So again, if you've got a critical access hospital site that's interested potentially in GME, starting with some rotations is a really great kind of starting point for those hospitals. Ashland is another hospital that has been very active within GME, and they have a longstanding psychiatry rotation with the Central Wisconsin Psychiatry Residency Program. They actually have an inpatient psychiatry unit at their critical access hospital, and they host several rotations every year for those psychiatry residents. It's been a really, I think, great experience for them. They've launched into creating a new emergency medicine fellowship. I believe that they're the first emergency medicine fellowship located at a critical access hospital, and they're starting on a path towards creating their own family medicine program. So I'll talk about them a little bit more later, but it's been really fun to see them develop a strong foundation for GME through hosting resident rotations. If you have hospitals that have a little more capacity or farther along in the process, a rural track program is another really great option. And we're seeing just an increase in the number of rural track programs. And a rural track program from a CMS funding perspective, at least half of the training needs to be at the critical access hospital site. Probably the most common model of a rural track program in family medicine is what we call 1+2, where they do 1 year at a large urban site. You'll hear about Dr. Bull's program, which is the model that they're using. And then they'll spend time the following 2 years at the critical access hospital site. So in the RRPD world, we have the OHSU Three Sisters program. They're going through recruitment for their first class right now. Those residents spend their first year at OHSU in Portland, followed by 2 years in Madras, Oregon, working at, and this is how the Three Sisters name came to be. They're working with 3 different sites. So it's a federally qualified health center, a critical access hospital, and a tribal clinic, all working in partnership to launch this new rural track program. So it's really exciting to see some of the innovative work that's being done in this space. We have a long established rural track program in Wisconsin, the Health Partners Western Wisconsin program. They spend their first year in St. Paul, Minnesota, and then their following 2 years are in Amory and New Richmond, Wisconsin. So again, that's in the western part of the state, kind of by Baldwin. And they actually are looking to expand that program from 2 residents per year to 4 residents per year, adding a third critical access hospital site. Hearing the enthusiasm from their hospital president with regard to their program and their success in training just really great rural doctors, they are thrilled with the idea of adding this third site, and really even more thrilled that they just recruited their 2 third-year residents who will be staying on within Health Partners. And then most recently, LECOM created a new internal medicine rural track program. This is set up in a more distributed model where the residents will actually be at Corey Memorial Hospital for all 3 years and then do out rotations for, things that they aren't able to get at the critical access hospital site. The third model, which isn't as common, but I think that it may be something that could grow in the future, and that's where a traditional GME program is primarily housed at a critical access hospital for all 3 years. The WSU Pullman program has launched this program, and they're kind of unique in the fact that they have a lot of specialty services right on site in Pullman and are able to handle most of the rotations just at their own site. They are doing some rotations as just a handful at a nearby couple of sites for things that they can't get right in Pullman. So again, depending on the critical access hospital, there could be potential to house the whole program at the critical access hospital site. However, there are funding implications. So we'll cover that on the next slide. And I want to first, before we get into funding, give the disclaimer that GME funding is complicated. There's a lot of nuance to the rules and different restrictions regarding GME funding. So I would encourage you, we'll talk later in the presentation about our rural GME website, our portal resources, which are available. Last month, there was a webinar on what's new in rural GME financing. And I would really encourage you to take a look at some of that webinar and some of our other resources and tools, because if you don't have someone within your institution or within the hospital that you're partnering with who has a deep knowledge of GME financing, that's where external help can be really helpful. So I'm going to, kind of frame this in a more advanced level, and we will get into this in the Q&A a little bit more, and John will share some more information about his particular program and how the funding is going to work. But I do want to, kind of just give a broad overview of how funding works with regard to a critical access hospital. So when we look at CMS Medicare funding, the Rural Track program, so that's where over 50% of the time is spent in the critical access hospital. The partner urban hospital is able to receive an FTE cap increase, and they are also able to claim the resident's time receiving reimbursement for DGME plus IME if they pay the resident's salary and benefits. In this particular case, the CA is considered a non-provider site. So this is kind of the ideal scenario from a funding perspective, is that, the critical access hospital has an urban partner that can then pay the salary and benefits and claim the resident's FTE, and get an FTE cap increase. The other model we were talking about earlier, like the Pullman model, that's where the CA is able to collect direct costs. They are, however, not eligible for GGME or IME, and they receive 101% of Medicare share. So in this scenario, it's not optimal from a funding perspective. I do know the Pullman program has been very successful in external fundraising and philanthropy to help offset the cost of the training program. But, in working with critical access hospitals, scenario planning and financial discussions are a huge part of the overall strategy with regard to GME and with regard to partnerships and who they may potentially be working with. In the case of rotations, and this is where, the rotations can be seen very positively by urban hospitals looking to, provide, rotations, maybe help augment some rotations that they need, or to provide additional rural experiences. In the case of rotations, a PPS hospital is able to claim the resident's time as a non-provider site. The other option, which again is a little less advantageous, probably for all parties, is if the CA claims the residents and gets the 101% reasonable cost reimbursement. So again, this is a little more in the weeds, but it's important to know that there are financial implications. For the most part, if they have an urban program and they're eligible for an FTE cap increase and the urban hospital is able to pay the salary and benefits, that's kind of the ideal scenario from a funding perspective. I do want to mention a couple of other options and things that are worth considering as you look at funding models for GME and critical access hospitals. And one of those is THC GME. Actually, on the THC PD side, we do have one grantee that is a collaboration between 3 critical access hospitals. They have created a consortium and they are partnering together to kind of create that traditional GME model amongst their 3 hospitals. They are doing a handful of away rotations for things like OB and inpatient pediatrics that they're just not able to provide at their hospital. And their plan is to apply for and receive THC GME funding. Currently, the per resident amount for THC GME is $160,000 per resident. There's hope that that could increase, but for this particular scenario, it could be, a break-even proposition for that consortium. But again, we do, as I've worked with hospitals in Wisconsin, we go through all the options. We go through all of the different scenarios with regard to funding, because you do want to have an open and honest discussion around what's this going to look like. How are you going to pay for the resident salary and benefits? How are you going to pay for the cost for the program, the cost for your program director, et cetera? You want to make sure that you're being comprehensive in your assessment. And then state funding is the other piece of the puzzle. Medicaid GME does vary significantly by state. I would encourage you to dig into, if you're looking at working with a critical access hospital, what state they're in, what the current scenario is. Critical access hospitals could be eligible for this type of funding. Again, if they're claiming that 101% of reasonable cost, they could potentially get Medicaid GME funding. But then there are also expansion grants. There's states like Wisconsin. We have expansion grants of $150,000 per position. I know New Mexico has expansion grants, as does Minnesota and some other states. And there are also program development and planning grants that are available in the range of anywhere from $500,000 to $2 million to help support and launch programs. But again, that varies by state, but it is important to look at all the funding options, not only for the residents themselves, but also the planning and development expenses. And planning programs, as we know, takes time. Planning a residency program can take anywhere from 3 years to 5 years. Sometimes programs are super fast, everything lines up, and they're able to launch within a couple of years. But more often than not, we see programs taking that 3 to 5 year time frame to develop new programs. And as you're developing programs, there are key steps in the process that can make things move quickly, or they can slow things down. And probably first and foremost, if you're working with a critical access hospital, is you have to identify who's going to sponsor this program. Are they going to join a consortium? Are they going to become their own sponsoring institution? Are they able to partner with a nearby hospital that can serve as their sponsoring institution? That's one of the first decision points in developing and launching a program. Similarly, and probably most important, is the community and stakeholder development, talking with the local hospital leaders, talking with the medical staff, talking with the local community, and finding out what level of support is there for this program. And many of our rural communities where hospitals are located, the hospitals are such a key part of that community that the community members are often very interested in helping support the program. I just was talking with an RRPD grantee the other day, and they were telling me that residents, I think it was you, Dr. Bull, you were telling me you were going to have some of your residents be adopted by local community members. And again, I think when you have that strong investment in a local community, you're able to really, I think, capitalize on the support, and that ultimately leads to success. The program accreditation process can take some time. John will talk about his program and all of the work that they've done to build a strong curriculum and to develop a strong program in those rural communities. There's also program director recruitment that can take a long time if you don't have an internal person who can take that work on. And then there's faculty recruitment and faculty development, as well as resident recruitment. So there's a lot of steps involved with launching a program. But fortunately, our Rural GME team, we've created a roadmap to hopefully help simplify this process. There's 5 different stages. This is, I think, the closest thing that we have to an evidence-based approach to creating and launching new rural residency programs. Stage 1, you'll see, is exploration, and those are a lot of the things that I was talking about early on. And I would say that the stage 1 activities are probably the most important. Identifying the sponsor, ensuring that there's strong leadership support, ensuring that the community supports the program, and that the local medical staff and local hospital support the program strongly as well. I've seen situations where a lot of the stage 1 activities aren't maybe completed, and you rush through the application, you get the program accredited, and then all of those things will crop up later. If you don't address them early on, those issues will crop up later. So again, I think this roadmap is a great model and framework to think about as new programs get launched. In our Rural GME portal, we actually do have a timeline that gets into even more specific detail around, how do you launch a program in 3 to 5 years? We have a timeline that has specific steps, specific activities to embark on. And if you're talking with a critical access hospital, to have a roadmap like this and to have a timeline is very helpful to help them envision, how long it really will take. They may be excited about the idea of training residents, but that runway can be very long. You could start those discussions about starting to train residents, but they may not be on the ground until 4 or 5 years after that discussion. So again, this, I think, helps frame the bigger discussion around how do you get a residency program started and how long it can take. I want to announce and share with all of you that we actually just updated the Rural GME website. I know some of you have logged in and have accounts. If you don't have an account, you can create one. That yellow arrow shows you where you click to create your account. All you need is a username and a password, and you can log in and access all of our resources, all of our tools, including that roadmap, including the timeline, including the webinar on funding and financing. And we have other really great webinars as well that we're happy to share. And HRSA has graciously allowed us to share that with the general public so we can grow more GME programs. I do want to take a moment and highlight a really great tool. I talked about how complicated funding can be. And one tool that I think makes things a little easier if you're doing any type of scenario planning work, looking at critical access hospitals, and I would caution a lot of you to really look at this hospital analyzer tool, because some of our critical access hospitals are actually not located in rural communities. And I mean CMS rural communities. They may be in a federal office of rural health policy. So that's what we call FORP rural. They may be a FORP rural hospital, but they may not be a non-metropolitan CBSA. And CMS will only allow funding in a non-metropolitan CBSA for that FTE cap increase. So again, this hospital analyzer, you'll see when you log into the portal on the left-hand side, there's a little icon. You can click on that and you can access the hospital analyzer. We have every single hospital listed that's filed a cost report in the United States, and we have their status. So I pulled up UPMC Williamsport, which is Dr. Bull's program. And you'll see that they're a rural referral center and established teaching hospital, and then they're partnering with 2 critical access hospitals that are non-metropolitan, so they're good. But again, take a look at the hospital analyzer tool, use this as a resource, confirm that your critical access hospital is in fact in a non-metropolitan CBSA, which is up at the top. And then I think what's really great is this, like I said, can get really complicated. We do have a glossary where you can click, where you see it says click for more detail on the right-hand side. That's where you can access the glossary and you can see what all the different funding implications are with regard to each hospital type. So now I'm going to also talk about funding to support rural residency development. I'm sure many of you are aware, but RRPD does support planning and development activities of up to $750,000 to develop new rural residency programs. To date, $54 million has been awarded to 73 organizations in 36 states in 6 different disciplines. Cohort 6 will be announced sometime in July or August of 2024. And I think what's exciting to share with all of you is that of our RRPD grantees, 19 critical access hospitals are training sites in cohorts 1 through 5. We hope to add more to this mix, but again, this shows you that we have a lot of training already happening in critical access hospital sites. And funding does support costs to create new rural residency programs, including accreditation, faculty recruitment, faculty development, and resident recruitment. And right now, if you have a critical access hospital in mind, someone that maybe you've been talking to, right now is the time to start that planning process so that you could potentially apply when cohort 7, the notice of funding is announced, hopefully later this year. And now I'm going to hand it over to Dr. Bull, who's going to talk about considerations in developing new rural residencies.
Yeah, so thank you, Lori. Just to kind of piggyback on what she was talking about, it's really interesting. 10 years ago, in 2014, we thought about starting a rural residency here in Williamsport, and we realized that we did not have enough GME support for that. We then, in 2018, joined with University of Pittsburgh Medical Center. And the good news with that is that they have a very strong sponsoring institution and GME department. And 2019, we were approached by them about starting a rural residency here in north central Pennsylvania. And out of that is where we ended up applying for an RRPD grant through HRSA, and we actually got it in 2021 then. And we're in our final year of the grant at this point. It's been very helpful for us to start our program. There are many expenses that, if you have the choice between dedicating the money towards patient care versus preparing for something in the future that's a little nebulous, you choose the patient care, and having a grant to cover those early costs were really helpful. I just want to kind of take a step back though, and review a few of the important considerations you might say when you're thinking about starting a new rural residency. And the thing is, I've had a couple people come to me and say, hey, I'm really interested in this, and how do I start this? And I would say the first thing that you want to do, if you're an administrator or if you're a physician that's really interested in this, um, you got to identify a local champion. There's so many times where barriers or energy is needed in this, and to overcome those barriers, you need somebody who's really passionate about it and really willing to go to bat for your program. The second thing is you need to identify if you're rural or not, and there's a great website that you can use, just Am I Rural? And it'll tell you whether or not you qualify as a rural site. Um, the I would say if you do not have a sponsoring institution, there is a way where you could actually become a sponsoring institution and apply for an ACGME application or accreditation. But if you're able to partner with a already established sponsoring institution, designated institutional officer, I would strongly advise that you do that because it's a lot of work to do both at the same time. And there are places that do it quite successfully, but having an experienced sponsoring institution when you're actually applying for ACGME accreditation is really helpful. Um, the other ones here, I think that Lori already talked about. The final thing here is just probably the importance of being patient. We started the process in 2019. All of you know what happened last couple of years with COVID. Trying to write an ACGME application during COVID was very challenging. And I had many evenings where I was working on it. Another challenge that we ran into was and I debated not saying this, but I think it's helpful to know, like we've had 3 different director of operations in the residency since we started. And, one of them, the second one, unfortunately, passed away 2 months postpartum. And it was a big challenge. And I say that because the process is one where you need people that actually are really committed to it and can see the long-term outcome. And there's a physician in North Carolina, Dr. Stephen Crane. He said this: building a rural residency is like planting an orchard. It's not picking up a bucket of apples. And I would say that that's really true. You're really looking for the long haul. Next slide.
Great, thank you, Dr. Bull. We're going to now share a few examples of rural residency development in critical access hospitals. And I'm going to share kind of the big picture Wisconsin view, and then Dr. Bull will share his experience at UPMC, and just really excited for him to share his story, but also really proud of the work that we've done here in Wisconsin. You'll see we've launched a total of 4 rural family medicine residency programs, and those are located on the map, and some of them are multiple sites, so it looks a little different. We also have a 5th that's been around for quite some time. But of our 4 new rural programs, actually 2 of the 4 are in critical access hospitals. So it's absolutely been a huge part of our growth strategy, and it will continue to be a significant part of our growth strategy, as we have 2 sites in Ashland and Hayward that are looking at a shared model very similar to the UPMC approach. I already talked a little bit about the Health Partners Program, but I just want to take a moment and highlight their beautiful facility in the lower left-hand corner. They just have a really great setup, really great program, and I look forward to seeing that program hopefully double in size sometime next year. In the lower right-hand corner, you'll see in Southeast Wisconsin, we have a new program. It is the Mercy Walworth program. And they have just done some amazing work to grow this program. And they are unique in that they are located in an area where they're able to recruit a lot of specialists. So they, have a really great primary care department, but then they're blessed to have a spine surgeon, a dermatologist, several orthopedic surgeons, and a pretty busy emergency department because they're located in an area that's kind of touristy. A lot of folks from the Chicago area come up. So their hospital keeps very busy. They have good ED volume. They have good PEDS ED volume. So they're a really great site to launch a critical access hospital program. And the way that they built the curriculum kind of plays on their strengths. Again, it's that, approach of right sizing to community capacity. Because they have those specialists, they're able to actually do all 3 years of training in Lake Geneva at their hospital. And they've been able to partner with their nearby site in Janesville, which is about 40 minutes away, to provide the urban rotations. Because of this model, because the Janesville Hospital, the urban partner, is able to claim the residents' time, the financial projections are, it's a break-even proposition. They're not losing money on the program, but more importantly, they're working to grow and sustain their primary care workforce. Because while they have this great kind of tourist community, and it's a beautiful area, all the folks who live in the community are longstanding residents, and they aren't, as they have high needs, and they have struggles, and housing impacts them, as does other things. They built a rotation with a free clinic nearby, so they're able to get the residents that experience as well. Up in Ashland and Hayward, this is a program that is in development. And any of you, if you're a cross-country skier, may have heard of the American Birkebeiner. It's a large ski race. That's up in Hayward, Wisconsin. And then Ashland is right on the shores of Lake Superior. But they just have two really great critical access hospitals with really good ED volumes at both settings. And they have been able to launch a program that I think is going to be very different in its flavor from the other program I was just talking about, where they really don't have a lot of specialists. They have family medicine physicians who really do it all. They provide full scope primary care. They do operative obstetrics. They really, kind of do their best to care for the patients in their community. And again, they're a little more resource limited just because of their location in far northern Wisconsin, as is Ashland. So again, it's going to have a very different look and feel. But because of that, they are looking to do probably the 1+2 model, where the residents will train at another site for 1 year and then spend time either in Ashland or in Hayward. So again, these programs are all very different. They're all very unique, and they're really built on what are the community needs for that particular area. And then, what are the resources that you have available locally? And if you don't have something available locally, can you find a partner that can help meet those needs? You can create a strong curriculum and ultimately, train doctors who can meet those community needs. So I'm going to turn it over to Dr. Bull, and he's going to talk a little bit more about his program at UPMC.
Yeah, so thank you. I just want to highlight a few areas about our program, and it might help you to understand the curriculum a little bit better. I saw there was a question as well about, board certified OB and surgeons, and fortunately at our two critical access hospitals, we have those. So we're able to meet that, and I'll talk a little bit about the housing here in a minute. But essentially, this is our mission statement, names, and, we've created an ACGME accredited integrated rural training track, so now we're going to maintain it. We actually have the ability to do lifestyle medicine training as well. In our main program here in Williamsport, we have osteopathic recognition, and both of our rural critical access sites, the site directors, ironically, are DOs that do OMT as well. So I haven't applied for OR yet. Lori's trying to encourage me to do that. I don't know yet if I'm going to do it, but it's certainly a possibility to be trained in OMT. Go to the next slide, please. So this is our curriculum, and I put hours of time thinking about this. And so you can see the 4 C's on the left, the pillars of primary care. And someone might say to me, what's the key thing to being a good family physician in a rural area? And I would say the number one thing is to have a broad-based core training. It's not whether or not you know how to do POCUS or some specific procedure, you really need to be able to have a very solid medical knowledge. And that's where that first year in a high volume center can be really helpful. And then the second and third year being trained in those areas of scarcity. Um, the other thing I wanted to highlight here, a lot of rural docs go out and do emergency care in family medicine. And so we're going to have an emphasis on that as well. And we're giving them all the option of ATLS certification. Um, when you go into a rural area, you may have experienced this as well. The physician's often the most educated person in the room. And so they're looked to as leaders. And unfortunately, a lot of us don't have a lot of experience with that. So we're going to try to get them some training for rural health policy, advocacy, leadership. And we have a rotation designated for that in the second and third year. Lori mentioned about the community engagement, other things, and this is the rural healthcare. I took some of these ideas from um, the um, the Australia's definition of a rural generalist, but the culturally sensitive care is really important. And where I worked in Appalachia, that's a very significant issue as well. And it's true for many rural communities. Next slide, please. So this is what our curriculum will look like. In the first year, they do night float for 2 months. We will not have night float in the second and third year, which is a huge draw. And again, with the new ACGME requirements, you only need an experience with surgery, but I know that in rural communities, being able to do procedures is really important. So I want them to have more than just an experience. Next slide, please. So this is kind of an outline on a map of what we're like. So on the bottom right there is Williamsport, and it's the home of Little League World Series, if you ever heard of them, of Little League World Series. We've been there for 50 years, and so we have 21 residents. The um, the um, the in the rural I'm sorry, in Williamsport, in about a decade ago, we had the most rural physicians in practice in Pennsylvania who were graduates of any other program in the state. But unfortunately, we've now become urban, which is one of the reasons why we wanted to start this. And an hour north is where Wellsboro is, and then an hour west is where Coudersport is. Next slide, please. And you can see what the participating site comparison is like. Coudersport is also a FAR level 4, which is the only place in Pennsylvania that's really falls in that designation. It means that majority of the population live 15 minutes or more from a town of 2,500 or less. And for us, we were able to raise the cap at Williamsport. We will be raising the cap, and our graduate medical education funding and like the GME and IME funding will flow through Williamsport out to those critical access areas. Next slide, please. This is our FMP number 1. The only thing I wanted to highlight here is that we are building this pediatric practice, and unfortunately, we did get some feedback from the ACGME that we really need to work on that. We got some citations on it, which is something that we knew that we would get because our site director there, who is a DO, is just new, and she's actually establishing this practice. Next slide, please. You can see as well, it's interesting, in 2019, when I started the process, both critical access hospitals had pediatric patients, excluding newborn. And then we had COVID come in. And unfortunately, when we went to pull the data for our ACGME application, Wellsboro did not have any pediatric admissions the previous year, and which was really a disappointment. Now we actually have 2 months of pediatrics in Williamsport in the first year, and we have a plan in place for that, which I'll talk about in just a minute. Go ahead with the next slide. And for Port Allegheny Health Clinic, which is in Cole, They have about 9,600 patients. It's a rural health clinic, and it's been there for a long time. Next slide, please. And for them, they have about 200 deliveries in that critical access hospital. They likewise had very few pediatric patients. Next slide, please. And finally, UPMC Williamsport, which is the clinic that I work at here in Williamsport. We have about 15,000 patient visits per year. And next slide. And our hospital has about 350 pediatric admissions per year with a little over 1,000 newborns. And we have a level 2 NICU, which means, again, the residents, when they come through here in their first year and they get the 2 months here, they're going to hopefully experience with pediatrics, but they also have 2 months of OB in their first year. So they're going to get experience with OB before they go out into that rural area as well. Next slide. So we had 3 challenges that we had to address. And one of them is the fact that we have 2 different sites, and they're 2 different primary practices for residents. We are not going to have them move back and forth. And there's only 5 rural programs in the country that apparently have this model. And what we figured out, and Dr. Longenecker and Lori were helpful with this, we're going to actually set up 2 different matching numbers for 2 tracks within the program. That way, the residents will get matched into the critical access hospital that they will be working in their 2nd and 3rd year. The next slide. The second thing, obviously, is pediatrics, which we've had a lot of talk about. And, our thought, number one is we want to scale to small places. So we can't expect that we're going to be able to provide the exposure that you might have in an urban setting. But we also want to maximize that exposure to pediatrics. So in the 2nd year, there'll be 2 months where they will round on any a newborn or pediatric patient in the hospital, and then working with a pediatrician in their office in an outpatient setting. And then we also have 3 months where we're doing what's we're calling a family medicine service, where they're going to be rounding on OB, peds, and then medicine. And we know that there'll be many days where there won't be OB or peds, which means that it's still going to be majority of medicine rotation. The third thing that I did was I actually put a extra rotation in the 3rd year in the spring for pediatrics, and it's going to be either outpatient pediatrics or ER-focused pediatrics, unless we find that their numbers are not high enough, then we'll have to have them go to a larger, in our case, it'll be down to Harrisburg, to a pediatric hospital to get more numbers. I don't think that's going to be the case, though. And then next slide. So somebody mentioned about housing. And, when we started looking at this in 2019, we basically identified that this was going to be an issue right up front. And so we started working with some foundations, and we were able to get a foundation to give us a grant that we've been able to dedicate to covering the cost of the housing in the 2nd and 3rd year. Now, the hospital owns 15 to 20 houses in Wellsboro, and they have a series of apartments in Coudersport. Now, when we were pulling this together, I used an old slide. I did not realize that I had a picture here from Peggy's Cove in Nova Scotia. And once I saw it, I was like, hey, that's pretty cool. It brings back great memories, but the apartment looks a little different than this. But either way, we're very grateful to the hospital, for both hospitals, for this generosity. And we're actually going to be providing housing. It's going to be an opt-in or opt-out for the resident, and likely it'll be tacked on as a stipend above there. So they'll have to be taxed on it as well. There's surprisingly a lot of details to get this worked out, but we have the money in the bank, and I have it budgeted out till 2030. So we're really excited about it. And that's my last slide.
Great. And I believe we are at time, and I think Austin has some parting words. I would encourage, I know we had some comments come in the chat. We did try to address those, but please feel free to reach out to any of these emails, ask questions. We want to help support this work. Just thank you for allowing us to share these stories, share a little more information, and hopefully inspire you to think about critical access hospitals for GME training.
Yeah, thank you so much, Dr. Bull and Lori, for this great presentation, and to all who joined us. If you have any questions, please contact us directly at aogme@acom.org. This concludes our webinar. Thanks again to everyone who joined us, and have a great evening.